It's live. Okay.
Well, hello, friends. Welcome again to another installment of Kidney Talks with the George Washington University Ron and Joy Paul Kidney Center. I am Reverend Dr. Kendrick Curry of the Pennsylvania Avenue Baptist Church here in Washington, D.C. And we have a wonderful program for you today. And I will have our co host come along with us to help us understand my kidney and my health. We have Dr. Clive Callender, who is a professor of surgery at Howard University and is the founder and chief architect, I might say, of the Minority Organ Tissue Transplant Education Program. And we will also be joined later by Dr. Joseph Keith Melanson, who is the chief of the GW Transplant Institute and a professor of surgery at George Washington University. And we have as our special guest who will talk about my kidney and my health. As we know him, is Dr. Jag. He's an internal medicine and nephrologist at George Washington University School of Medicine. And we're just so excited to have him here with us. Welcome, Dr. Jag. Hello, Dr. Calendar. And I'm just ready to hear about my kidney and my health.
Thank you. It is a great pleasure to be here back in this setting, and it's good to see old friends and make their reacquaintance. And I'm going to talk a bit about kidney disease. And I'm a transplant nephrologist by practice. I take care of transplant patients, but I'm also a nephrologist who takes care of kidney disease. And while our aim is to perform transplants for the population who's in kidney failure, but also our overall aim is even to prevent kidney disease from happening in the very beginning and to take care of them. I came to DC to start off, 10 years ago from Georgia, and one of the things which I came when they came to the capital here, it was astounded me to see the amount of kidney disease and the acts and the lack of access and the equity issues in terms of both end-stage disease and transplantation. And over the last 10 years, I think the GW transplant program has done a phenomenal job in addressing many of those issues to at least to some amount to mitigate this. Um, so let me go and see. The next slide is, so what does our kidneys do for you? Um, I mean, I would say that it's the smartest organ in the body. I'm a nephrologist, but it does a lot of stuff. It clears your toxins. It does make sure your electrolytes, your potassium, your sodium, everything is regulated. It regulates your blood pressure, regulates bone metabolism. It makes sure that we have the right amount of fluid in the body. Make sure that we have enough hemoglobin. It secretes a hormone. It does a lot of other things just that, other than making urine. So when we talk about kidney disease, a kidney is an organ which is something which is extremely important to our survival. And when you have kidney disease, it affects almost every organ system. And so, what are the causes of kidney disease? Lots of causes of kidney disease, but suffice it to say, the most important ones are diabetes and hypertension. And these cause about 70% or 70 to 80% of all the causes. And it's important because this predominantly, I mean, kidney disease also affects African Americans more than the other races, and diabetes and hypertension is much more common in the African Americans. The other diseases are disease called what we call glomerular diseases, like lupus, for example, polycystic kidney disease, which is the inherited kidney disease. The other disease due to we can take, medications can cause kidney diseases like Advil, Motrin, non-steroidals. Sometimes you can have tumors causing kidney diseases. And of course, when you get a kidney transplant, the transplant can fail and you can end up back on dialysis, and that's becoming increasingly seen as a cause of kidney disease itself. So, like I said, the problem with the kidney disease is like an iceberg. Most patients do not know that they have kidney disease before it's too late. And time and again over the last 10 years, I keep on telling Dr. Malon's son Keith that whenever we see patients here, it's almost always when I ask their story before they start dialysis, more than 50 or 60% of the time, they discovered that they have kidney disease just before they start dialysis or at the setting when they started dialysis. And the sad part of it is that it is preventable if we monitor the high risk groups for kidney disease way before that. And so one of the things is that, I would make it is up to the medical community, the largest community. We have to educate the public about kidney disease, that this is a disease which needs to be caught early to make an intervention so that we can the slope of the curve, so to say, the progression of kidney disease can be altered, and sometimes it can be stabilized. And so it's very important that in terms of treating kidney disease, we have to take actions to prevent it and detect it early. Kidney disease usually, and I'll go into it, is into 5 stages, and by the time it's stage 2 or 3, even stage 3, it's too late. By the time it's stage 5, you need to start dialysis or need to get a kidney transplant. So if you look at, why is it so important? Because it's a huge deal. If you look at the number of the kidney disease is an epidemic. It's a pandemic in the US. And if you look at the number of patients on kidney disease, about 20 plus million people have chronic kidney disease out of a population of, let's say, 330 million. And if you look at the number of people who are on dialysis, it's more than 500,000 people on dialysis. And that's a big number in terms of, and this is also more in the minorities, in the African Americans, in the Hispanics, in the lower socioeconomic groups. So it's an unfair burden on patients who don't have that much access to healthcare and testing as well. Now, if you look at, when I came to DC, I thought I was coming to the capital of the country. I came from a small town and a small city in Georgia called Augusta, and I said that you're going to have wonderful care in DC. You're going to have good hospitals and stuff like that. And what did I see here? It was just not the capital of the country. It's also the dialysis capital, the ESRD capital. If you just look at the graph there, it's all in red. It's a very high incidence of kidney disease in Washington, D.C. And that's what actually brought me here in the first place, to start a program along with Keith and address these issues. And it's not something which is, if you look at the prevalence of kidney disease, it's just a graph with years and keeps on going up, the number of patients who have end-stage disease. And I can tell you it goes up to 2012, but you can extrapolate the graph to this 2022. And although it has started to plateau, it's still a huge number in terms of population risk. Like I said, about 20 plus million people got chronic kidney disease. And also, if you look at who gets it most, again, if you look at it, this is African American, this graph, and this is Hispanics and the other races. The most of the patients who get it disproportionately are also African Americans. And why is it a big deal? It's not just that you get kidney disease, your kidneys don't work, but a lot of other things go wrong with your body. You have an increased risk of heart disease, strokes, and you end up, mortality due to this disease is higher. So the average person who has kidney disease has got a lower decreased lifespan. So much to say that if you compare it with cancer, most people would not know it, that having kidney disease is just next alone to lung cancer in terms of mortality. If you have colon cancer or breast cancer, prostate cancer, guess what? Your chance of dying are much less. Again, that tells you that this is something we have to take seriously, because it's not just a question of having kidney failure, being on dialysis, but it affects your lifespan as well. Because we divide kidney disease into many stages. Stage 1, stage 2, stage 3, and stage 4, and stage 5. If you look at, we measure kidney function by many blood tests. One of the tests we mentioned is how well the kidney processes blood, and it's called GFR. And the normal GFR is 100 to 125. And anytime then, based on that, you have the stages. Stage one is it's got to be 90 or higher. Stage two is going to be 60 to 90. And then three is going to be 30 to 60. Stage four is 15 to 30. And stage five is less than 15. Stage 4 and 5 is when patients start to get sick and start to have complaints. That's when you start to notice that your blood pressures are higher, you have difficulty in passing urine, you're getting short of breath, you're getting fatigued, you're tired. This is when you think to seek help. The stage 2 and stage 3A, they are silent. Most patients don't even know the difference at that time unless they get a lab test, they are checked. And that's when we need to intervene. And the stages are important for people to realize that, when you get your lab test and you get this test, you need to discuss with your physicians as what is this creatinine, what is my GFR, what stage I am at, what needs to be done at each stage. So this is extremely important. We need to educate our public that this is something we need to have. The onus is on us, but also on the generally we need the as a program. I think the NIH, the National Kidney Foundation, the ASN, all of them are doing a great job, but we need to do a better job, because this is very, very important, because I cannot overemphasize the fact that this is where these stages is where which we intervene, we can at least make headway in, if not preventing, and at least retarding the progression of kidney disease. But few are aware of it, even those with the kidney disease stage 3 and less. If you look at the number of people in a study, they said how many people with CKD stage 3 and higher did even know that they had kidney disease. And this was more than 30% of patients were not even aware of it. And this is something I come across. I see patients in the clinic and I ask them, okay, did you go to the doctor? And they're diabetics, they've been going there for the last 10 years. And I said, somebody must have told you that you have kidney disease, that your kidney function is not normal. And then you ask them, they said, no, not really. They just told me something was wrong. So I think one of the things is, this is again a question of education. This is a question of, getting the message across that patients at high risk, whenever, or any patient, when they go to the physician, they get the annual physical, and just like you want to know what your hemoglobin is, you want to know what your cholesterol is, whether you have diabetes or not, one of the things we need to know is how good is my kidney function, what is my GFR, what stage I am in, and what are they going to do about it. So we know that if you do something early on, we can make an impact. And the last 30, 40 years have told us this. Simple things. If you control your blood pressure and bring it to goal, which is less than 130 or 80, and specifically with certain group of medications called ACE inhibitors or ARBs, which actually decrease the protein and it's been shown to decrease the progression of kidney disease, we can make headway. We know that if we control our diabetics well, especially the newer group of medications called SGLT2 inhibitors, which have come and which also decrease the protein, we know that the progression of kidney disease can be, we can slow it down. We know this, and data shows us that. We know that we avoid the nephrotoxic medications like the Advil and Motril, it can have an impact. So now large data over the last 50 years, and we know that. So we need to, once again, we need to catch them early, make sure that these treatments which have an impact on the progression of disease need to be instituted consistently, and everyone who has CKD. And the reason I'm saying this, if you look at data, are we doing a good job? Not really. Even in patients who are identified as chronic kidney disease, many of them are not at goal blood pressure. Many of the diabetics are not on this medication called ACE inhibitors, which can be helpful. So even in the ones which we diagnose as having CKD, a significant amount of the population are not on the medications which they should be. So who do you test? People who are greatest at risk. African Americans, especially with with family members who have got history of diabetes, high blood pressure, patients or anybody who has diabetes or high blood pressure or cardiovascular disease. So people at risk people whose family members have a diagnosis of CKD, people who are ethnically African Americans, they need to be tested. And the testing is very simple. All it needs is a blood test and a urine test. So doesn't cost a whole lot of money. It costs a few cents to get the test done, but it can make a huge impact. So two simple tests. You can get a blood test, you can get your creatinine, then you get what you got your GFR. You will know whether you're chronic kidney disease, you don't have chronic kidney disease, what stage you are. You can check for the protein. Albumin is a kind of protein, and you can check a test in the urine. You can get a ratio of that, and it can tell you whether you're spilling protein. Even a simpler test is a dipstick. Everybody can does a urine analysis. That dipstick shows protein. It may be a marker of kidney disease and kidney damage. However, the albumin or the microalbumin is much more sensitive. So this is something which can be done simply, doesn't cost money, and in fact should be done on everybody's annual physical. Everybody should be tested, not just diabetics. I think the whole population needs to get it. I've seen so many times that people get annual physical, creatinine is not included, GFR is not included, a urine test is not included. So this is not something which is very difficult. This is not rocket science. This doesn't cost a whole lot of money. It does not. You don't need to get fancy tests done. All you need to do is patients need to get the blood pressure checked once a year at least, screen for that, get a urine test, get your blood test done. That itself will pick up patients much earlier, and it needs to be consistently. Of course, it all ties in with access to medical care, and this is another discussion I'll be going into that. Early treatment makes a difference. If you don't treat, this is what happens to your kidney failure, your GFR, it goes down. On the other hand, if you do treatment, the slope slows down. So we know from data, this is large scale data, hundreds of thousands of patients. We know early treatment for chronic kidney disease with appropriate therapy makes a benefit, can get you few years. Instead of progressing to needing dialysis and transplant in 5 years, you may last till 10 or 15, and makes a huge difference. What is better than, I always say, if you have kidney disease and you're on dialysis, the best thing is transplant. But I also will follow it up. The best thing is not to get a transplant and not to be on dialysis. The best thing is to not stabilize your chronic kidney disease and just be there with the CKD3 or. So I always tell patients, if given a choice, I want neither. If given a choice between transplant and dialysis, I choose transplant. But giving me a choice between the two and the third one, I would not have anything. So that's where our aim should be. So when you have so now that let's say your chronic kidney disease, you need to know what stage it is, and then the right therapies need to be instituted. And God forbid you end up having this end-stage renal disease, you need to have an early referral to dialysis, which is the therapy of choice. So they need to refer you when your GFR is 20 ml or 25, I would say, or even 25. 20 is the cutoff, but I would tell patients is when it's 25 or even 30, 25 to 30, you need to ask them at least get yourself educated, ask for a referral to a transplant center, a nephrologist. You need to see a nephrologist when you're CKD stage 3 right away. Till stage 2, maybe primary care can manage it. After that, it has to be a nephrologist that's been involved in the care. And if you're an end-stage disease, if you can qualify for a transplant, you need to get a transplant. That is the therapy of choice for people who are qualified to get a transplant. Why do you do transplants? Very simple. You live longer. You have decreased death due to heart disease. And specifically younger patients, the diabetics, they are the ones who actually benefit the most. Of course, your quality of life, any dialysis patient would know that. You can eat what you want to eat. You can drink fluids as much as you can. You can travel. You can work. You get an overall sense of well-being. You can have kids. One of the greatest things is to have a family. And, if you're a diabetic and get a pancreas transplant, you can get off insulin. Of course, the best outcomes would be if you get a transplant even before you start dialysis. So early recognition, getting the right therapies. If your kidney disease progresses, getting referred early to get a transplant. So transplants at this point in time, after 60, 70, the first transplant was 1954. So we have been doing this for a long time. So we have come a long way. It's a rather common surgery now. We did about 24,000 transplants last year in the US alone. So we are at a point where your kidneys are doing very well in terms of the 1 year survival, but the long-term survival, like the 1 year kidney transplant survival is 98 to 99%. Patient is also 98 to 99. Long term, we need to do a better job. Still, at the end of 5 or 10 years, many of our patients end up back on dialysis. We need to do a better job on that. But we have got newer medications. We treat the infections better. The problem is everybody does not get a transplant who needs to get one, because the number of patients who are waitlisted or who need the transplant is more than the number of transplants which we can do. So that's the major issue here for us. So if you can look at it, some facts, this year, more than close to 500,000 patients have had a transplant in the US altogether. And we have done about 24,000 kidney transplants, close to 800 kidney pancreas. And about 6,000 of them are last year we did living donor transplants. But more than 100,000 still await a transplant. So you can do the math. If you've got 100,000 people waiting, about 24,000 get a transplant, 75 don't, and you add to the list every year. And close to about 5,000 patients die every year awaiting a transplant. That's not a statistic I'm proud of. I think we need to do a better job in addressing these issues. And it's a demand and supply issue. Like it's in a graph, you look at it, this is just, the dialysis keeps on increasing, the number of transplants just cannot keep pace, and the gap keeps on widening here. The other message I want to let everyone know is it's living donor transplants are better. So if you just look at even how long the kidney lasts, this is a deceased donor transplant, this is a living donor transplant. Look at the number of years, it's almost double. And also there, if you get it done before you start dialysis, your kidney lasts longer. So it's important, the type of transplant, we need to push for living donation, especially in the minorities, because it's kind of it has been dogma for many years that the living donor rates are not high in minorities because they don't come as donors, which is completely wrong. We need to do a better thing of pushing the message. I can see here that we have got a lot of wonderful donors from African American families, and we have gone on to transplant our patients. So this is something which should be a focus for every program. It's not just to push for living donation, but also in the minorities, the Hispanics and the African Americans. So this is a consistent message, and it's one of the things our program is very proud of doing here. Now I'm going to talk a little bit of disparities. I came to this place because of this, and my interest is in disparities in transplant and promoting. So, transplant is available to everyone, but within quotes, because access to transplantation is not the same across different groups. Whether it's pre-transplant, and it has an effect on who gets transplanted, what's the access, and also its effect on post-transplant outcomes on the population. But we are making certain things. So there are factors for that, socioeconomic factors, insurance. So unfortunately, you need to be insured to get a transplant. We don't have universal health insurance. I'm a proponent of it. So although when you get on dialysis, you do get Medicare, but the patients who are not on it, there is still a small and significant group of patients who fall in between, who don't have any kind of insurance and cannot get to be on a list. Education, health literacy, it is important, and this is something which is again, it needs to be addressed. And patients' misperception and mistrust, and there's a long history of that dating back historically. So this is something which needs to be which is a factor. Access to specialist care. Very few of our patients, we look at it, 100 patients, maybe even 50 or 60 of them have not even seen a nephrologist until they start dialysis or shortly thereafter. So that needs to increase, because it's been shown that if the nephrologist gets involved in the care early on, then they are not only taken care of better, but they don't progress to ESRD. It takes much, much more longer. And they're in a better state of health to receive a kidney transplant when that happens. Because getting on the list also means that you need to be healthy. So it does impact on that. And also physician provider misperceptions. I mean, one of the things which I said, a lot of people believe that living donation is something which African Americans were not coming forward to. That was wrong. The other misperception is older patients don't do well. No, age is just a number. If you're physiologically, if you're doing well, you can benefit from a transplant. And geography is another thing about access. Comorbidities, of course, because African Americans have a higher incidence of diabetes, and these comorbidities do impact on both pre and post transplant listing. So that needs to be addressing that. They need to be addressed before even they come there. They are more likely to be sensitized, which means they have more antibodies. Why do they have that? Because they don't get care early on. And when you don't get care early on, you don't get, your hemoglobin is not monitored. You don't get injections to keep it up. You get more transfusions, which leads on to having more antibodies, which means that your chances of getting a transplant is more difficult then, because you have more antibodies. Then the fact is, when you get an offer, then that kidney may not be suitable for you. And the ABO blood group distribution, the way the ABO blood group is distributed, it's racially, it's a different distribution. But when the offers come in, that disadvantages the African Americans. And again, quality of kidney, increased time on dialysis of patient. One of the main things is the longer you wait on dialysis, the more sick you become. So the earlier referral to transplant, you're going to be shorter time on dialysis. So it is another issue that patients need to get referred, even preferably pre-dialysis, but on dialysis as soon as they start dialysis. Of course, now there's been over the last 5 years, the country has instituted policies which have made it much more easier for this referral to take place, and in fact mandated it so that this referral takes place, and actually incentivizes nephrologists and the physicians to refer the patients early. Okay, these things lead to post-transplant. These disparities have an effect post-transplant, because our patients then have got increased acute rejection rates. The pharmacokinetic, the immunosuppressants have a differential action depending on race, and we have to be cognizant of it. Medication adherence needs to be tackled, and we need to be contextual. What is adherence? What is not adherence? What affects it? At times it's the copays, the financial wherewithal of these patients, the fact that there are multiple medications. So all these things need to be. We can't just lump adherence to one pocket. We need to look at it more granularly and see how we can address it. And of course, lack of insurance financials always makes a big issue, and genetics of it. Over the last 10 years, there's a gene which has been identified, which may play a part in progression of kidney disease, APOL1, and that needs to be, there's a lot of research going on. This may also have an impact on these disparities. Part of the thing is the new allocation system in transplant has tried to address these disparities. So now, when I started this in transplant, the wait list was when the patients got listed on transplant. And then we said, okay, this is not fair. What about the patients who get referred later? So we said, when they start dialysis, we'll count it from the time they start dialysis. Made it a little bit more fairer. But then we went one step further. We looked at the way we measure kidney function. We realized that the way we used to measure kidney function, we used to have a different way of doing it for African Americans and for Caucasians. The formula was tailored a little bit differently. That put them at an advantage. Now that you have a race-neutral GFR, that wait time will come back to them. For example, if somebody gets a transplant and is an African American, and if you can find out somewhere in the medical history that they have a GFR of 20 ml, even 10 years before, that 10 years get added to them. So that has made things better. Definitely the ABO, the allocation based on A to B, now that we can do an A to B, patients who have donors who have an A to B can be transplant recipients with B. That will make it a little bit more, it's better for the African Americans. And also giving more points for having sensitization will also make it more easier for the African American group of patients to get transplant. But that cannot alone that will only touch it a little bit. Still, the major thing would be We need to do education and outreach, and that's what MOTEP has been doing a great job of in it. But we need to do consistently across the whole country. We need to do health literacy. We need to awareness of CKD, early referral. Now that we have social media and all the new, we have to use our new technology to get this message across. Everybody has a smartphone now, so everybody. So these are things which I need to get there. And we need to treat, and it's not just kidney disease, it's the whole body. I mean, whether your obesity needs to be tackled on, which is a big issue. I have talked about hypertension and diabetes, so this is going to be a major issue, how you address it. Of course, the other things we can look, medications can be less side effects, single day regimens. We can have monthly injections, immunosuppressants, which may make it easier for compliance. Digital tools, I talked about smartphones, tailoring the immunosuppression to your particular genetics or ethnicity. And of course, I'm a big believer that lifelong coverage of immunosuppressants, which are there, which happened last year, a couple of years, so many years, we were there and patients were not covered beyond 3 years. So that's been a big that is one of the biggest advances. If you ask me what are the biggest advances in the last 10 years, it's not the medications like belatacept, it's which has been the biggest advance. Promoting living donor transplantation, doing paired donor exchanges, ABU and compared, all of those things will add to the number of transplants, and especially in the minorities, if we emphasize like we are doing in our institution. And of course, this is something we've been doing, also pushing the envelope in transplanting patients with HIV and hepatitis C, using hepatitis C kidneys. And the other things is more medical, what we do. We personalize medicine, we do medicines-based, we do surveillance biopsies using biomarkers, we do genetic stratification based on APOL1, we look for them. So these are things which kind of help address in a way the outcomes, make it personalize the outcomes, make it more race specific, and so that we don't lump everybody into one basket. One of the things I always say, they look at me, I'm a South Asian, but none of the clinical trials have been done on South Asian. Nothing is validated. So when you go back, I'm from India. We don't need to use as much immunosuppression. We use much less because we realize that Indians don't need that much immunosuppression. But unfortunately, there's a bias, and they're never used. This is an underrepresented number of patients in any clinical trial across the world. Same thing, historically, African Americans in clinical trials earlier on were not represented well. So what we get from, even in a thing, we have to make sure that it's based. The protocols we use in any place should be contextual, based on your demographics, your patient population, and that will actually increase your outcomes and actually affect disparities as well. And I think it's not just transplant and nephrology; it could be a continuum. We are all in it together. So it starts on basically early detection of CKD, institute therapies to impact on it, refer the patients early, and treat just not the CKD but the comorbidities. So, and as a transplant nephrologist, I'm going to say it again. While transplantation remains the best modality to treat ESRD, it's much better to prevent it in the first place, not have it at all. That should be my goal. In fact, my goal is not to be even employed. I'll tell them, it better not anyone have a transplant. So if at all, try to reduce CKD. That should be our main goal. So what can primary providers do? Again, recognize and test at-risk patients, educate patients about CKD treatment, focus on diabetics with glycemic control, blood pressure control, use of ACE inhibitors, and early referring to transplantation. I always end the slide with the first transplant happened in 1954. And this is the twins. It's a living donor transplant with identical twins, the Herrick brothers, and that is in Brigham and Women. So we have come many years, and what was considered an experimental therapy is now therapy. It is accepted, it's standard of care, and it should be the standard of care for patients with ESRD. And we have to address this, it's holistic thing. And again, we can talk about disparities, we can talk about them, but we have to walk the walk. We got to make it happen. So it's something we have to tackle at a policymakers level, at the congressional level. We have to change things. Still, we need to make sure that financial issues, insurance issues, we need to make sure that when drug development is there, we take into effect who are we addressing it to. We include all the stakeholders, all the minorities, everybody is there. So all of these things need to be included in it to address and that is important. It takes a village. I would always say the best advocates are the patients. You need to advocate for yourself, educate yourself, advocate for yourself, force the change, ask your providers the questions, make sure that things are, if you're hypertensive, why am I not this medication? I heard about that, I should be on that. I think an informed patient is a better patient who also it should be the catalyst for change. And the education should be right, not at the level of patients, it should be at the schools, tackle obesity, diabetes at the early age. All these things should be done at the level at the church, at the churches, at the schools. We have to educate our healthcare providers, be it primary care providers, nurses, social workers, because they need to know, because they also spread the message, dialysis nurses. So, and we change the policy organizations, whether it's Congress, it's the government, it's you have a say in it. Patient care organizations have become very big. I mean, now, American Association of Kidney Patients is the largest growing organization in nephrology. Why is that? It's a patient-centered organization. They have their input changes what trial gets funded, what the FDA does. They have representation on FDA, CDC, everywhere, NIH. So I think it's not just the government. We need to it's not just legislation, but all of this. And then I think we can come to a point where we can make a headway into it. We can reduce chronic kidney disease. And that those who need a transplant don't have to wait like 12 years, 14 years in some states, or here 6 years, the average wait time. We can cut back on the wait times. We can improve our long-term graft survival. So, and I'm blessed to be among this, and I always consider blessing to be in the transplant field. And I always say that that is our passion and vocation, and to restore the quality of life through renal transplantation. And thank you very much for inviting me, and I'm free to ask any questions. I'm more than happy to answer.
Well, thank you so much, Dr. Jag, for a fascinating presentation. People had already started dropping questions in the chat, and I encourage them to do so. We want to get to those and also hear from definitely Dr. Melancon and Dr. Callender. One question in the chat from Phyllis is, how do you know that you are in kidney failure?
Like, again, I said, most patients don't know. That is the big problem. By the time you know, it is too late. So what you do is, of course, if you ask for symptoms of kidney failure, you would say you start to make less urine, your feet are getting swollen, your blood pressure, you got high blood pressure, or you're fatigued, your loss of taste, your appetite is not good. But that is the end state. That is by the time you can't make much headway other than refer you to nephrologist and for dialysis, and then this thing. The point I wanted to make is, most of the time it's silent. They don't know about it, and you pick on them. There are no subtle signs. You could walk. I could have kidney failure. The only reason I don't know, I don't. I just checked my lab work and my creatinine was normal, and my urine mass was normal. So I think in high risk groups, the message I want to say is, yes, these are the symptoms. You should, but more importantly, if your family member has kidney disease, if you're a diabetic, you have high blood pressure, you are African American, it is important to get yours at least you can go and get your blood pressure checked in CVS. You don't need a machine. Okay, it doesn't take any money. A urine analysis and a simple blood test, it's less than $1 or $4 or something. I think you can get it done, and even if you don't have insurance, you can come to our hospital here. We have clinics on every Friday or something. Every week we have one clinic. There are many such clinics here in the city. NKF does a KEEP program where they have clinics all over the country periodically, and they screen high risk. So there is availability of that. But I also think that people need to be educated that if you're going to your primary care physician, and let's say I am I've got a family member who has got kidney disease. I need to talk to the primary care physician and say, hey, what's my kidney function? What's my GFR? What
Right.
do I have protein in the urine? So I think that's how it changes them, because this is what I've seen as, in 2023, still, I don't know what Keith thinks. I think more than 50% of patients don't have any idea that have kidney disease when they come in. And it's not when they come in, when they walk in for the first time, they don't have it.
Yeah. Any comment, Dr. Calendar, Dr. Melanson, with
Yeah,
regard?
I have a comment because this is a wonderful, comprehensive presentation, Dr. Jag. I congratulate you on such a wonderful presentation. But one of the things that bothers me recently is I saw a relative of mine who got a creatinine done, and they did a GFR, and the normal GFR, according to her doctor, was a GFR of 60. Now, you and I know that, and you mentioned it earlier in your talk, that 100 to 125 is something that you shoot for. And the stages of kidney disease start from that and go all the way down. So I'm concerned that the level of what the physicians are using to try to diagnose kidney failure is much too low. To have somebody to be alarmed only because the GFR is below 60 is to me is much too late. The other issue that I'd like you to address is the fact that most people of color who go to the doctor on an annual basis may only get a creatinine. And may or may not get a creatinine, but they may only get a creatinine, but they are not going to get a urine protein. And so therefore, those patients are going to wind up down the road, coming up, just as you said, to have this silent killer, to find out that their GFR is suddenly at 25. And what has happened is the doctors missed the point that the GFR was much lower, but it was never checked because they only did a creatinine. They didn't do the urine protein to make an earlier diagnosis of end-stage kidney disease. So my question is, what can we do about that? Many of our Medicare patients, they don't get a urine protein test. They might or might not get a creatinine. How do we get it so that this is almost mandatory for people of color over the age of 50 to have urine protein analysis and a GFR, serum creatinine as well?
I think it needs to be mandated in the patient care model that the physicians have to order it. I mean, I really think it needs to be I know we don't do like mandates, but all these are things like, if you come to a hospital, somebody checks your blood pressure, a nurse in a clinic room. Why do they check your blood pressure? They don't have to, but it's a mandate that your blood pressure, vital signs, or body weight is checked. So similarly, if you're on a yearly basis, there should be certain labs which should be checked, and Medicare should be audited and say, if you don't, that physician, this is an ACO, they can do this, and this in a policy level. The other thing which I wanted to make a point is, interestingly, my colleague, Dr. Shankar, just asked me a question yesterday, and it impacts on this. She said, Dr. Jag, what do you think about this creatinine of 1.6, 1.5, which is normal report in LabCorp? And some of that, the GFR is low. And I said, really? I said, yeah. She said, yeah. So I'm just saying, this is LabCorp is the biggest lab for us. And they have this big thing, this normal. And then the patient looks at it, my creatinine is 1.45, and it's a 70-year-old person. That gives you a GFR of probably 43, 44. They missed that point. They look at it, the provider says, your creatinine is okay. She had just asked me because yesterday I said, we need to stop, these are major issues which need to be addressed. And because it gives you a perception to the provider and the patient is everything is okay.
Sure.
And when everything may not be okay, or maybe you need to dive in deeper. And this is something I think we need to push for change. And I think things are starting to move But you brought up a very good point. I mean, if you don't know what is normal, if the patient not educated about it, I mean, it's just like my blood pressure is okay. What's your blood pressure? 160 or 90? What? Okay, I thought it was fine. So it's a lack of okay. Now you have to educate them what is a normal blood pressure. A lot of it is, I mean, what MOTAP is doing. We need to, and I think we need to empower our patients. That the
Sure.
first, if you can't make the change there, I said make the change the other way around. Drive the change from the patient side.
Just quickly, someone from actually my neck of the woods in Dallas, Texas, originally, they have a question that's I think is important. She says, "I have been referred to a kidney doctor next month, and this is Bertha. I feel all the medication I've had doctor putting me on since 2019 now, they say my EF GR is high now as a result of the medication. What should I be asking the doctor when I go? In other words, how do we begin to help her advocate for herself?"
I think knowledge, right? It's a number. High is what is high. So the first question the patients ask me, for example, I said, my blood pressure is not my. This is every day I get this. My patients will come and, how's your blood pressure? It's good. What is good? Tell me a number. Because what is good in your mind is not good at what it should be. So the first thing, what is it? What was her EGFR? What is it? Just because I don't know what high means. High means is it the other way or this way? This is a very non-specific term. We need to know what the number was, what it is, and if the person still has chronic kidney disease, is the appropriate care being given. So the first question is you need to sit down with your physician, go over and ask these questions. So each lab, I know sometimes it's a pain. I think the patient say, can you tell me why this is abnormal, what this is? But it's good practice to say, hey, nowadays labs will put it out in red. Most of it, some of it is not, we can say, but that's a good point. Please tell me why it has changed. So I think part of it is having the conversation and asking for the thing. I think most physicians will welcome this conversation, will welcome an opportunity. That I would always want a patient who is very informed ask me this question. So I think one of the things is, I don't know what high means, but the other thing is, in terms of absolute numbers, has the kidney function worsened, improved, or stabilized? Regardless of that, if you still have chronic kidney disease, you need to be paying attention to the whole thing. So unless, I don't think it would have normalized. The question is, what is going on? Yes, they may have instituted treatments and it may have gotten better, but that doesn't mean that they are out of the neck of the woods. You still have chronic kidney disease.
Yeah, one of the things with regard to this is, and I think it's a very good question, and you need to be educated. But sometimes folk don't know what they don't know. And so as a result of that, it's a difficult situation to begin to ask some questions when you just flat out don't know what to ask. You've given us some directions. When someone says hi, we need to just address, well, what does high mean? How do you begin to explain that? And there may be some other questions, and there may be a whole webinar on just questions you want to ask your primary care physician to understand your reports. I mean, these lab reports, because LabCorp, they're probably the largest around, and they have these ranges, but the average person wouldn't know what these ranges would mean, right? Yep. So we really need some assistance, and take the time to make sure that we're able to have some answers to questions we don't even know about. So educational programs like this are good. One other question, and then I want to go to Dr. Melancon as well. Brenda Moore Pirtle says, what should I do if I'm in stage 3? How can I prevent further failure?
I think you need to know. So there are some general things and there's some specific things depending on what the cause of the kidney disease is. Generally, your blood pressure needs to be well controlled, okay, 130 or 80, broadly speaking. If most would agree that if you can take a group of medications called ACE inhibitors, you should be on it, but they may be individual. So I can't give specific recommendations. If they can, they should. If you're a diabetic, it should be well controlled. Make sure that the other comorbidities like high cholesterol, like weight, obesity if they're obese, avoiding things which hurt the kidneys. The most common thing is medication with something over the counter. So that's another thing, right? People just take a boatload of pain medications. Everything is available. So things they should be aware of what can, and diet. Diet is a kind of medicine. So as your kidney disease gets worse, you start to, you may need to be on a low salt diet, a phosphate restricted diet. You may need to manage your fluids. So you need to make sure that you see a nutritionist if you can, if you have access to one. So at least I think once your chronic kidney disease stage 3, if you can see a nutritionist at least once a year in your practice, you can. It be otherwise. These are the things which we need to make a thing. So, and also be sure that monitor your thing, because you're at 3, you're going to be at 4. I hope she doesn't progress. I hope the progression is extremely slow if she does. But there may come a time when the 3 becomes 4, and an early referral for transplant would be at that time, good. But I think you need to keep an eye, because this is the point. 3 is now you're getting anywhere between 45 to 60, somewhere around that ml range, and things start to happen. You start to become, your hemoglobin tends to drop, your phosphorus starts to go up, your bicarbonate drops. So you need to see people more often. This is the time I usually see my patients every 3 months. By the time they're chronic kidney stage 3, as a nephrologist, I want to see them every 3 months. So make sure that you get seen, so that you need to be monitored also.
Yeah, Dr. Melancon, any follow-up comments?
Yeah. First of all, great talk, Dr. Jag. I think everybody gets to see why Murali is in the foxhole with me. When you're fighting a war, you got to have soldiers, and he and I partnered in building our program. And when I talk to patients, this is what I'm talking about. Meaning, you need a doctor like Dr. Jag, right? You need to find someone that's going to follow you. I always say it's not the first visit, it's the follow-up visits that make a difference. Because, you can even get the right information, but that first visit doesn't mean anything. It's the follow-ups, right? It's kind of like a first date. First date don't mean nothing.
Watch yourself.
It's the courtship. It's the courtship. I know y'all do things a little different down there in Texas, but I'm just saying.
Mine was actually here. Thank you, sir.
But to your point, but to that point, I came back from Houston and Louisiana. I was back home, and I was there. We had a death in my family, but as you know how those things go. I got to meet with my family and go to lots of places where there was lots of food to be had. And let me just say this. I don't think down there that they have figured out that there's green food, like lettuce and spinach. And everything was fried, lots of salt. My point is, one of the hardest things for us to do as healthcare providers is to get people to change their behavior, right? And to get people to change their behavior is almost like setting off an alarm, right? You can't just tell people, you need to change your diet, or you need to decrease your salt. That goes in one ear and out the other. They don't understand what that means. In order to get people to really change, you've got to shake them up, right? Look, I just saw, I don't know if you guys saw this, there was a report from the WHO that said that the number 1 killer in the world is high blood pressure. Right. High blood pressure, something that's very, very treatable, and it's cheap to treat. But we do a horrible job in doing it. Why? Because of what we're talking about right here, right? So what we have to do is we got to figure out how to wake people up, right? And the only way to wake them up is to be alarmist. You got to get people to understand, which is true, that if they don't treat their high blood pressure, if they don't treat their diabetes, if they don't intervene early, then they're going to have problems. Dr. Jag is perfectly right when he says there's a big difference. The woman asked about stage 3 kidney disease. Well, the number one thing is she needs to go see a kidney doctor.
Yeah.
Because everything in her life is going to be different once she starts following with a kidney specialist versus if she's trying to do things on her own or working with a primary care doctor. So a lot of what we need to do is just to get people to start being armed with data. And like Dr. Jag said in the beginning, the best thing to do is not to have people need people like us. And the way to do that is to get them to change their behavior very, very early. And they have to be armed with data. I think what Dr. Callender did with MOTEP is what we need to utilize in this area, which is educating people, right? So you explain to them how much salt is in a normal serving of what they might be eating in my area of the world, like rice dressing, and fried chicken and fried fish and my mouth is watering, but it's not good.
And gumbo.
Right, yeah, exactly. Right. That stuff is not good, or at least it's supposed to be a delicacy. Right. I have cousins that eat that every day. That's not a delicacy. I mean,
it is good.
So I think that when people become educated, I tell people all the time, which I was telling some of my family, you can go buy a blood pressure cuff for $20 at CVS, right? I have one at home. I give them out to my family. Why? Because that numbers, what, like Dr. Jag said, they don't even know what normal is. Normal is that top number should never hit 140. That bottom number should never hit 80, right? That's where you need to leave. And if it's high, something needs to be done. And if something is not done, it's going to lead to problems. So I appreciate so much what Dr. Jagadisan said, but the answer is always the same, and the answer is education. We've got to get people to know what questions to ask. The reason why rich people do better is not simply because they're rich; it's because they have better access to data, and then it can provoke them to make the proper changes. It's either on purpose or through ignorance. We don't have the data, and not having that data allows us to kind of put our head in the sand like an ostrich and think, oh my goodness, what happened? Now there's a problem. I mean, people kept asking me that. I'm like, well, you're 100 pounds overweight, you have high blood pressure, and you're diabetic. What you thought was going to happen, right? So you've got to get people to wake up, because alternative is not right.
We definitely want to get them woke, so to speak. We want to hit a couple of other questions because we're getting near on our time. This is a fabulous conversation. Phyllis Glover says that I had a breast removed 20 years ago and have been told I can't have a live donor. Why?
Well, okay, let me answer that one, because that's an easy one. That's crazy. So,
okay. All right.
Having a breast removed, which might have been breast cancer, I don't know, but it's okay. Even if it was, that does not mean you cannot have a live donor. You can definitely be transplanted. So for every cancer out there, we have we present the patient in our presentation meeting, and we decide, well, how long do they need to be out from that cancer? And the worst cancers possible usually is no more than 5 years.
That's right.
Most breast cancer, if you survive, is going to be something that we usually will say you only need to be out 1 year from that operation. So that's absolutely baloney. If you had a successful breast operation 20 years ago, there's absolutely no reason why you cannot receive or be a live donor. If you were a normal person that wanted to give your kidney and you had even breast cancer 20 years ago, we would say it's okay. So you definitely can get a live donor after 20 years.
Well, there's another question by Bridget Garth Young, and I'll just jump to the part where she asked questions. She said, I just had a renal ultrasound and everything is clear. However, I feel like that I need to do more. I also just cleared a UTI prior to the ultrasound. I got an ultrasound because I was still experiencing pain in my back. And she goes on to say that lab reports are essential. I review mine all the time. I have the ultrasound reports printed and on USB and have sent to my primary care doctor. usually I can interpret the results. One of the things that's important that she's talking about is obviously Miss Bridget is one that is really trying to pay attention to her health and trying to keep the results and the data with her. How important is it to keep track of your own records and learn how to interpret the
I
results?
I mean, I think that is absolutely important. I would encourage everybody to keep a file like I do. I think I tell them, in fact, one of my patients said that yesterday. Yesterday, I was evaluating a patient and said, "Have you done your health maintenance?" And the patient told me, "You know what? I get everything done at my birthday and I'll forget it." I tell that to patients: pick a day, usually birthday, birth month, get everything, have a file. Nowadays you don't need a file, you can put it in your phone. There's so many apps available which track things, so you should know the information is there. It's so, because let's say you go to some other state, you get sick, you have something, you have the data with you. Yes, it's accessible through nowadays, EMRs do talk to each other, we can get, but nothing like having the information with you, because it's so much better. You can track things, you can tell, you can see my cholesterol was that much, that it was X that 1 year ago, I'm doing a better job. Wow, that's great. Let me do. My weight has come down. My blood pressure is better. I think it is very important to keep, just like you keep your, what can I say, your insurance, your car insurance, your registration, everything in the car. Just like you keep you keep your recipes in a recipe box. You need to get your bank statements everywhere. You need to keep your health records in a place where you have access to it. I mean, this is your most important thing, as important as your deed to your house and things like that. I mean, that's absolutely, this is, I mean,
Yeah, and I'll just say, and I totally agree with what Dr. Jack just said, and I'll just add to that I think it's one of the best advances that's happened in American medicine in the last few years. People can go into my chart and they can get everything. And I'm gonna be honest, it drives some doctors crazy that you get the results sometimes before they've even reviewed them, which is great. So, and you can also send those results out, and you can get your own second opinion. So I have people sending me their results from hospitals in another state, and I can look at everything and give them a real time answer to whatever question that they have. So Dr. Jag is absolutely right. That health information is of such importance, and you need to really chronicle what is going on, because it's like I was saying earlier. It's the trend, right?
Sure.
You get a snapshot in time, which can tell you a lot, but you get so much more information by the trend of what is going on. And so, yes, I think getting that information, holding on to that information is important. In this case, if this lady really doesn't have kidney problems, and it sounds like she was having lower back pain, then that lower back pain needs to be worked up. I agree. You start with looking at the kidneys, but maybe your kidneys are not the issue unless you had chronic problems. So if your kidneys are not the issue, then something else needs to be investigated as to why you're having this lower back pain.
Yeah. Dr. Callender, any comment from you?
No, I'd just like to say that this has been a great session. And I think if we can get everybody to recognize that you need to know what your health is. You need to know what the numbers mean. Health literacy is all about having your health in terms that you can understand. And some people don't understand what the creatinine of 1.6 is. That's high, very high. And so I think that the health literacy of your lab details becomes very, very important. And so I think that this program has caused everybody to rethink that. And hopefully that there will be made, some of those changes that are necessary will be made so that people of color will no longer find out about how bad their kidney disease is when it's too late.
Yeah, and I'm going to just follow what Dr. Callender just said, because, again, I've had a few people that interact with me recently, and I found out that this is a common issue. And the issue is that people will feel ashamed because maybe they have some bad habits, or they haven't followed up like they should. They haven't done their prophylaxis or their care like they think they should have. Okay, that's fine. Nobody's perfect. So just because you haven't done that in the past doesn't mean it's not time to catch up. We're non-judgmental here. You come
Right.
in and then let's start anew from wherever you are. But this idea that you're ashamed and then therefore you don't want to interact with the healthcare or go see the doctor, that's crazy. No. Come wherever you are and we will start anew. Wherever you are in the process, we will try to help you get to the right point. So I don't feel ashamed, because look, none of us here are perfect. Dr. Calendar, Dr. Jag, Reverend Curry. Well, maybe I'm perfect, but I mean, the point is, none of us are perfect. But we need
That part will
people
be
to move
edited.
in the right direction.
Dr. Jag, why don't you get ready to close us out? Any final comments that you would have?
I would thank everybody here, and I think Dr. Kanda, who's a legend in his own time, and Dr. Melanson, who's my friend and partner, and Dr. Curry, the good work you're doing. I think it's a blessing for me to be involved in this what I call this avocation of transplantation. It's a privilege and a pleasure. But I also think that it's my job after so many years. It's not even started yet. I mean, we are just making a dent, and I think now with my aim, I think somebody is asking me, what do you want to do for the rest of your life? Other than transplant, I want to make sure that we make a dent on chronic kidney disease. We just can't keep on having the numbers increase, and we can't keep on doing more transplants. That's not the answer to it, because we know it doesn't fail. The numbers don't lie. We can't do 100,000 transplants in even 2 or 3 years, even as great as we can. I think that we really need to start addressing it. And a part of the thing is not just education, but I think we have to wake up to the fact the way healthcare is administered in this country, the access to it, the inequities in it. I think we need to take it seriously, and because if we don't do that, I mean, we can put many band-aids before the whole blimp looks like a big band-aid. Okay, so you really need to redesign this thing. And I think now, for people in positions like Dr. Calendar and all, I think we need to also talk to the people who construct policies. I think changes are coming, but I think we need to start doing that also.
Well, I definitely love that. Anytime you have to deal with people and in organized spaces, you're going to have to deal with some sort of policy, some sort of reg. You mentioned so many great things. The presentation was amazing. And as always, Dr. Calendar, Dr. Melanson, been simply just fantastic in their comments. I just hope that everyone that is watching will lean in and watch even more with regard to these kidney talks. Don't take it for granted. This is part of your education process and program, and we're just trying to help others come up with a better way of answering the pressing questions that have been going on. We're here in DC. Has some of the highest incidences of kidney disease in the nation, and we want to see you do well. So those that are struggling with kidney disease, we tune into this program, tell your friends about it, and we're just so excited that we can have Dr. Jag, Dr. Calendar, Dr. Melanson share with us today. Thank you so very much. Again, another Kidney Talk installment with the Ron and Joy Paul Kidney Center at George Washington University. Thank you so very much, and be well. Bye-bye for now.
Bye-bye.
Bye-bye.